depending on where you're joining us from. We're delighted to have you here today to join us for the next in our CFN webinar series. The topic of today's webinar is Advanced Care Planning in Primary and Long-Term Care. We became much more aware of what we want, how to approach the subject, and what can be done. Today's presenters are Dr. Michelle Howard from McMaster University, Dr. Tamara Sussman from McGill University, and Dr. Sharon Castellanen, also from McMaster University. My name is Jeanette Prorock, and I'm Manager of Special Projects and Initiatives at CFN, and I will be your host for today's webinar. Following the completion of the following the completion of the presentation, we'll give audience members the opportunity to ask us many questions as time permits. If you're not familiar with Zoom, at the bottom of the screen, you should see a Q&A button. Please feel free to enter your questions there throughout the presentation, and we'll ask them of our presenters at the end of the presentation. A reminder that the webinar slides and the video will be available for viewing online within 1 to 2 days of this session at cfn-nce.ca/webinars. And we invite you to share the link to this webinar with any colleagues who may have been interested, who have been unable to join us today. And that's where you can find all of CFN's webinars from our webinar series. A reminder of upcoming webinars. So next week, February 23rd at this same time, 12 to 1 p.m. Eastern Time, we'll have the second part of today's webinar. For that session, we will have Dr. Gloria Gutman and members of the Diversity Access team from Simon Fraser University Gerontology Research Center. She'll be presenting to us on culture matters and mobilizing advanced care planning. We also have webinars scheduled on March 3rd and March 10th. A note, though, those are Thursdays, the departure from our usual Wednesday date from 12 to 1. For each of those, we will have Dr. John Hurdes and Dr. George Heckman speaking to us about better targeting, better outcomes for frail elderly patients, the Babel Project. So a little bit about today's presenters. So Dr. Michelle Howard is an assistant professor in the Department of Family Medicine and an associate member of the Department of Clinical Epidemiology and Biostatistics at McMaster University. Dr. Howard completed her doctorate at McMaster and her MSc at the University of Toronto. Her research interests include evaluating and improving primary care models and understanding the mechanisms and impacts of interprofessional care in primary care practices. Our second presenter is Dr. Tamara Sussman, and she is an associate professor in the School of Social Work at McGill University. She obtained her undergraduate and master's degrees at McGill and a PhD in social work at the University of Toronto, followed by a postdoctoral fellowship at the Murray Alzheimer Research and Education Program at the University of Waterloo. Dr. Sussman's program of research focuses on how health services and systems impact older adults and their family members, including spousal carers' experiences with home care, older adults and family members' experiences with transitions into long-term care, barriers and facilitators to the delivery of effective interventions for depressed older adults and their care partners, and most recently, the needs and experiences of more marginalized older adults in long-term care, such as previously homeless older adults and older adults identifying as gay, lesbian, bisexual, and transgender. Finally, Dr. Sharon Castellanen is a professor and the Gladys Sharp Chair in Nursing in the School of Nursing at McMaster University. Dr. Castellanen is an associate member of the Department of Family Medicine at McMaster University. Dr. Castellanen's research program is focused on improving the quality of life for people living in long-term care homes with a particular focus on implementing a palliative approach in dementia care. So thank you to all of you very much for joining us today, and Dr. Gutman for also joining the panel who will be presenting next week. And with that, I would like to turn it over to our presenters today to speak to us about advanced care planning in primary and long-term care. Again, we became much more aware of what we wanted, how to approach the subject, and what can be done.
Thanks, Jeanette. Hi, everyone. Thanks so much for the opportunity to present our work to you today and next week as well, as you heard. So I'm going to be starting the presentation and doing a little bit of an introduction overall to what this entire project was about, the different components, and then I'm going to present the results pertaining to primary care section of our project, and then I'll turn it over to my colleagues to talk about their work in long-term care. So this was a one of the CFN transformative grants that came out a few years ago that our team was awarded. So the overall vision for our project was for older Canadians living with frailty to receive person-centered, goal-consistent care near the end of life. So this was kind of our guiding vision behind all of our work. And our mission was to increase the uptake, impact, and access to advanced care planning for older Canadians living with frailty across primary care, long-term care, and hospital settings. So this is a schematic that shows kind of how we work together. We called ourselves like a federated project because we had specific teams working within the larger group, looking at advanced care planning in different areas of the healthcare system because they all have unique settings and contexts. So over here on the left, you can see in this first column arrow, we have the primary care group where we worked in family doctors' offices. We had the long-term care homes group, and we also had a study taking place in the hospital sector. So you're going to hear about the first two of these today. And overarching all of the projects, there was work done by Gloria and her team to ensure tools are sensitive to diverse groups. So we know advanced care planning is an issue that may have different needs across people of different diverse identities, and Gloria's group really looked at this across all these settings, and we'll be sharing those results next week as well. So in phase one of our project, our general goals across all these settings was to adapt and tailor advanced care planning tools for older adults living with frailty to the context of care. Phase two, to screen patients for frailty and implement and evaluate the advanced care planning tools with them. And phase three, take those learnings, refine the tools, including the results for tailoring to diverse groups for broader dissemination. And cutting across these aims, we worked to include the patient's perspective through patient engagement, and our stakeholder engagement was also quite broad with working with stakeholders and keeping in touch and disseminating results to stakeholders that are involved in advanced care planning across Canada. So that's our overall schematic that represents what our project did. Our team in this grant, the original principal investigator was Dr. John Yu. So we really want to acknowledge his leadership in making all of this happen and bringing us all together. He's since moved back into a full-time clinical role as an internist in Mississauga, but he has been, of course, very integral to this. And we are also a group of 32 investigators from multiple disciplines and 16 universities. We had 3 patient advisors, around 20 research staff across all our projects, and some international collaborators, and 42 partner organizations that we have kept in touch with. So today, as I said, we want to share our findings from our experiences of testing advanced care planning tools in primary care and long-term care. So I'll jump now into the primary care part of the work. So improving advanced care planning discussions in family medicine. And we have our principal investigators here I want to acknowledge. We were a group that worked across several provinces, as you can see, and an amazing group of research staff who interacted with clinics and patients and kept everything running smoothly. And also our co-investigators who have been involved for quite a while with our teams in giving us more perspectives from the clinical perspective in advanced care planning. So this was our team in primary care. And our sites that we worked that I really want to recognize, where we actually did the field work, were New Westminster Family Practice in BC, which is close to the BC Centre for Palliative Care, like across the street, in Sunridge Family Medicine Teaching Clinic in Calgary, Alberta, where Dr. Amy Tan was working at that time, which is, but both of these were large multi-physician practices, and Sunridge was an interprofessional practice as well. So we undertook to increase advanced care planning conversations in primary care. So we know there's lots of evidence for the benefits of advanced care planning, but some work needed to still be done to understand how to really implement these tools and optimize their use in this setting. So we wanted to support family physicians and allied health practitioners in primary care to have early and ongoing advanced care planning conversations with their patients. So that's the perspective we take in primary care, that because of the longitudinal relationship, we can leverage this here. So we evaluated a care pathway in Alberta and British Columbia family practices. And this was supported, this was a multidimensional intervention with multiple steps and support. So there was training and education of the clinicians. There was a conversation guide used to guide the discussions, patient-facing tools to increase the feasibility and quality of advanced care planning conversations in primary care. So we were really about taking the tools that are already developed and seeing how we can get them into use. Our evaluation consisted of pre and post patient and SDM or substitute decision maker surveys of advanced care planning engagement, using some validated surveys for that to see if people increase their confidence, knowledge, level of readiness. We also did a post survey of the patient experience of what they thought about going through this care pathway stepwise approach to advanced care planning in their practice. And we did some focus groups and interviews with the practitioners involved. This was based from a lens of normalization process theory, which is one implementation theory that looks at how to socialize and routinize new practices in organizations. So what we did, essentially, this shows our basic steps. We recruited based on some selection criteria that we gave to the practices about who they thought might be at risk of nearing end of life in the next couple of years. And we also assessed a level of frailty. We asked participants to identify and bring a substitute decision maker to this process if they could. Allied health professionals had education and tools to document values and goals as the next step after meeting with patients. This was then these initial conversations and tools that are shown down below here were summarized in a structured format and given in advance to the physician, who then met with the patient at a subsequent visit to kind of work through their own contextual situation as the patient. So looking at their own health conditions, letting the physician know what the patient was thinking about their values and wishes and goals, helping them contextualize those wishes for their own situation so that they could eventually come out with a better idea of their advanced care planning. And then this was documented in Alberta. It's the green sleeve they use. Each province used their own kind of systematic documentation process. So we tried to hit on all of the known barriers, such as patients not being ready enough or engaged, not having a systematic process, involving allied health professionals. We tried to address these different barriers and facilitators from the literature in a kind of a structured care pathway, which had been really not used up to this point. So down here, you can see the tools that were used for engaging the patient initially. Speak Up was used in BC at the time. Conversations Matter was the tool that was publicly available in Alberta. And then when patients came into the process and they met first with the allied health professional to learn about advanced care planning, we used a values clarification tool, which helped people think about different priorities and goals that they have, and they went through an exercise for a few minutes to actually trade off and pick what are their most important priorities and goals. And the allied health professional person also talked through the serious illness conversation guide, tool made in the US that's quite well known now and used across a lot of settings in Canada. And they started the patient on this journey of discussing what's their understanding of their illness, what are their important goals. So they went through this guide to the point they could and recorded the discussion before the physician conversation. And then the physician takes over and has really that more focused conversation about the person's health situation, specifically for how that applies to them. So that was our care pathway. In terms of what was different from the usual process versus what we did new here, just to summarize, usually the conversations are informal and unstructured or improvised in primary care. We implemented something that was formal and structured and phased with steps. Decision-making is usually guided by health condition and prognosis. So it's more of a treatment focused kind of conversation often. And we shifted this to a more holistic approach to decision making, taking patient preferences into account. So that was the grounding of the conversation. Physicians have initiate the conversations. So it's usually just the physician, but in this pathway, physicians refer patients to a process, and there's help from support staff and other allied health professionals playing an excellent role in that. Usually discussions are unstructured, but here they became structured and had greater depth and detail. Typically, there are no tools used. That was really the main crux of our intervention, and now the intervention is supported by tools. Usually it's a process that is self-directed, so the physician might give patients some booklet to take home and do independently, but here it was more supported by the allied health and the education. Often it was happening ad hoc without dedicated appointments scheduled, and it would often fall by the wayside given many priorities. So here it was more likely to be completed because of the scheduling and the proactive approach. And typically there has been no standardized documentation, although that's changing in some places, but here we had some clear standardized documentation that was created with the clinicians that could go into their EMR. So this is a little bit busy slide, but just to show you that we started and enrolled 80 patients, and they went through sort of a first initial research recruitment visit, and then they met the allied health professional, and then visit 3, they met the physician. And so by the end, 57, we did manage to have 57 complete the process, and 54 did their final follow-up research questionnaires as well. So that was the flow through. So the average age of patients was around, we did actually include in our data the series. We did the same process in an internal medicine clinic. So even though not quite primary care, it was an outpatient clinic that had an interest and a focus in this topic in BC as well. So patients were between 72 to 80 on average, around half male or slightly less half male in some settings. The majority in the primary care identified as white Caucasian ethnicity, less so in the internal medicine clinic, and mildly frail or higher, around just under half, but slightly more in the internal medicine clinic. And substitute decision makers, not everyone brought someone, but we had 37 people who did that, around 63 years of age, and lesser proportion males, so more proportion of females. That's the substitute decision makers. So often, this is the age mean age, I think, reflects a combination of adult children or spouses as well. So what changed for patients and SDMs in terms of their survey scores of ACP engagement? So most of these scales go on a scale of 1 to 5. So means were quite high at baseline. So self-efficacy increased a little bit, readiness increased more. And the actions are the 6 questions that relate to what did people actually do. So did they nominate a substitute decision maker? Did they talk about their wishes? And this was where the greatest increase was, likely because of the actual nature of the intervention itself. So that greatly improved in terms of moving people from just thinking about it to doing things. And the results were quite similar as well for the substitute decision makers. So all of these were statistically significant as well. In terms of our interviews for what clinicians thought, and the thematic analysis of this also kind of, I did present a little bit of that went into those, what were the differences between the usual care before and the new process. Also, the interviews played into that as well, but some examples of what people talked about in our interviews, 12 MDs and a social worker. In terms of workflow, they felt the work was fairly easy to fit in, and it was a bit more streamlined. They felt that there were better discussions, so more structured, people coming in with very clear ideas about what the discussion was going to be about. So it was easier in that way. So by the time people had talked to their physician, they had already had a good handle on what the conversation was going to be like. Accountability, the study brought advanced care planning in these clinics to the forefront and reminded clinicians of the importance to do it. And documentation, there was lots of endorsement of the tools. So without the tools, they'd been trying to do it makeshift. They didn't have the structure. And they also gained a better understanding of their patients' wishes and desires, made it easier to help them guide some of their decision-making based on their values, rather than just their health prognosis alone. There were challenges also. It can still be a challenging conversation to have, especially around the topics that usually come up around resuscitation and then some of those specific decisions. So trying to educate patients, you have to come up with some examples, and all the patient wants to know if they're in that position, is it going to be okay? And you just can't say that. So that's always going to be the difficult part of the conversation. The patient experience. So we asked people from before to after the conversation what changed for them. So most felt that there was an increase, at least somewhat or a lot, in their clinician listening to them, mostly greater confidence with that their care in the future would focus on their goals. They felt heard and understood. Sense of control over decisions was largely endorsed. Sense of peacefulness, kind of about half and half. This is whether it increased a lot or not. Some quotes, I knew that it was coming, that I needed to do it at some point. It was helpful to have someone work through the discussion with me. I feel like I have an idea of what to expect in the future, more knowledge, and feel more peaceful, more confident that my children will deal with my decline and death appropriately. So a range of interesting comments, and I think it's really important to always get the patient's perspective, because I think everyone has a little bit of a different idea of what this process means for them personally. So our conclusions were that the care pathway was helpful for clinician engagement in advanced care planning, and the patient experience was good coming out of it. It was a structured process that clinicians felt was helpful. Some structured processes can definitely overcome some of the barriers that exist. In terms of a sustainability idea, I guess that came out of our thinking from the results was that it still is fairly labor intensive. So linking patients in primary care upstream to community-based advanced care planning education was a recommendation that came out. So let's make use of all the community resources and education opportunities where patients can become much more familiar with this before having a conversation in their doctor's office. Some more areas of work are needed on figuring out this relationship with the community and sustainability to enhance sustainability in primary care. We didn't delve too much into the SDM, but more work really is needed to understand what SDMs are thinking about their roles and how they can have tools that are going to help them as well, or how they can engage in the best ways in the process with their family member or loved one or person they're going to make decisions with. Considering the clinician recommendations on this topic, again, they're really around sustainability. So having a feasible, light version of the care pathway, perhaps. And we also are now considering, of course, which we've been in for a while, the virtual advanced care planning in the context of COVID is something that is still to be understood better. The role of allied health. I think we found some better roles for allied health in this project, so that should be kept on the radar. And of course, community education, how does that all fit in here? So these are some of the future research ideas or areas of exploration that could be undertaken. Yeah, so I'll pass it over to our next team. Thanks very much.
Thanks, Michelle. There's some questions in the chat, but I guess we deal with that later for you.
Yeah, I think we can do that at the end. Yeah.
Okay, great. So hi, everyone. Really excited to be here. This is a joint effort, as Michelle had already suggested, by a huge team. And this is our sort of more focused long-term care team. Myself and Sharon were the leads for this long-term care component with many other collaborators and dedicated research staff. We also just want to showcase our partners. Maybe Michelle, if you could change the slide. We had a number of partners helping us with the implementation. The Alzheimer's Society was a key partner as well, as was the Conversation Project, who developed a series of tools that we ended up adapting to the Quebec and Ontario context and using in our studies. So in the long-term care arm, our aim was to improve end-of-life care by increasing advanced care planning uptake for residents and families. So we hadn't done quite as much work, Sharon and I, in the space of advanced care planning prior to embarking on this. So we started in a little bit of a different place than the primary care arm, where we were first interested in exploring how advanced care planning is coming up in long-term care. What are these conversations, if at all, that are already happening? Can we identify tools that could potentially be usable and feasible? And then train our staff and actually implement and evaluate these tools. We ended up selecting one workbook, and Sharon will talk a little bit more about those two components. So with the exploration of what's going on, we started with a chart review of a number of residents who'd been living in long-term care over a 6-month period. And we were really just looking in the progress notes to see what are the care issues and how often are those issues kind of dealt with in the current, and how often do staff, at least by virtue of recording, actually use and leverage those discussions to ask about what might be important to you in future if something like this should change, just to see what's happening. So we ended up with 78 charts that we looked at in this sort of open-ended progress notes. And we used the CHESS score, which is an inter-RI based score, largely because all of our long-term care homes use that tool already as standardized measure. The CHESS score of 1 or less than 1 as a marker, because advanced care planning, or the notion of advanced care planning, is supposed to be done with somebody who has capacity, who's in sort of an earlier stage of an illness trajectory, to talk about some of the things that they may want in future. So we presumed that the charts we were looking at should largely be reflective of people who would have relatively reasonable health stability. So one of the findings, I realized I have a lot of things flying in here, Michelle, so you might have to click this a few times. Not the best planning, probably one more click. We basically looked at how much of this was current, pertaining to in the moment interactions, and how much of this was future, pertaining to sort of futuristic issues. So in the next slide, as one might expect, many more of the interactions were based on current care, what people want right now, and quite a bit less was based on turning those conversations also into a future discussion. So much like Michelle was noting in primary care, of course, with the understanding, it's not appropriate to be talking about future care at every moment, but left in the sort of naturalistic element, we see a lot less discussion about sort of planning for the future, at least as evidenced in the charts. So within here, what we did note was that daily activities was the most commonly discussed issue. So unlike maybe you would find in a primary care environment where it's a lot about health care and health decision-making, here, food and intake, walking and transfers, these are issues that emerge a lot. Very rarely were those issues turned into conversations around potential future care issues. So here's an example. You'd see something in the chart. Edith continues to be upset over changes to her diet. I can't have bread at breakfast. Now I can't have cake. This is not nice. The sense that the diet has been changed. You don't pick up from here that there's been much of a conversation, at least documented, with Edith having some say in how she wants to balance risk versus pleasurable food. And certainly, no discussion around what could happen in the future should intake issues continue to emerge. what are the risks in eating certain foods and what is important to Edith in terms of her care. So this was sort of on our minds a bit as we went in. Social was another piece where lots of discussions and documentation about who's important to whom in long-term care. Once again, very rarely were these turned into potential wishes for future care. Here we actually do have a good example of someone who did document. John expresses a fear of dying, fear of being alone when he has to die. He hates that he has a lack of control about time. He wants time to do things. He wants to say a proper goodbye to his wife. Here we have an understanding of what's really important to John and the opportunity, should things take a turn in that direction for John, that we know saying goodbye, that we know, sort of taking a bit of control is important to him, and the ideal would be to give opportunities to actualize some of those wishes. We did find that in terms of treatment decisions, and this was largely around hospital transfer or the continuation of medication, that we probably need to click this one more time too, that here we saw a little bit more in the way of future discussions. So most of the future care plans had to do with things like hospital transfer, resuscitation kind of questions, and what people might want to have happen and what the costs and benefits of that are. So a little bit more around location of death and preferences around that emerged. And I think if we click one more time, we have a bit of a quote. This here is more to do with a power of attorney who declined sending a resident to hospital and asking for comfort measures in the home, with an understanding that that's what the resident might have wanted in that particular situation. So we decided that we were interested in exploring a little bit further what tools might be available for long-term care homes that kind of suit maybe some of the issues that long-term care homes are dealing with, a lot of sort of psychosocial oriented issues. So first we did a focus group with long-term care home staff to kind of get a sense of how feasible and acceptable is the idea of using a tool in long-term care, and what kind of things would they want to see in a tool. And then we followed that up with a targeted content analysis of available tools, looking for those particular things. So we had 32 participants in our focus group, and we located upwards of 600 tools. So in the first result, we definitely were told that there's a self-use directed tools would be helpful. Things that give specific conversation prompts, specific things to reflect on, sort of ranked scales, things that really helped people figure out what they should be thinking about and talking about, and that maybe required staff follow-up, but not staff to have a full awareness of how to direct a conversation. Affirming what we saw in our chart reviews, psychosocial content was incredibly important. So we don't just want a tool about resuscitation and medication management. We need to know about people's social wishes and spiritual issues and walking and ambulation issues. And, the length matters. Sort of medium, paper-based felt really important because access to computers isn't so prevalent. It might be different now, but at the time, a paper-based version was sort of desired. So we hopped into the world of publicly available tools. And we actually found, of the 600, only 32 that had psychosocial content that also is paper-based and a bit directed. So we can very clearly see why many people think about medical directives and confound that with advanced care planning. That's what's out there in the world of tools. And of the tools that we found, what we found were, even with the psychosocial reflections, they were often kind of general, like, what does quality of life mean to you? Which isn't a bad question, but sometimes can be very difficult for people to unpack without specific prompters. So a few less tools existed that had sort of some nice specific psychosocially oriented reflective questions. What cultural or traditional practices are important to you? That gets into quality of life, but it's a little bit more specific. And then moving from reflection to communication, a lot of the tools didn't quite move into helping someone think about, okay, now that you know this, what do you want to tell your SDM to think about in the event that you're not in a position to speak for yourself? So from this evaluation, we did settle on a tool that we thought fit the bill. Nothing's perfect. The Conversation Card Starter Kit is a tool that we used because it has a version for family members, for SDMs, for individuals with dementia. And what we did was we revised it with some sort of back-end information about some of the legal contexts in the province of Quebec and in the province of Ontario, just to be a bit more accurate in terms of language used and all the rest of it. I'm going to move on to Sharon now, just to talk a little bit further about the training and the implementation.
Great, thanks, Tamara. We'll do a little tagging. We're used to that. So Tamara's given you a nice introduction to kind of how we chose the tools and some of the earlier work, or baseline work is what we like to call it. And I'm going to now move on and talk about some of the intervention and the evaluation of the workbook with my slides. So one of the things Tamara and we learned very early on in our work together, we started off looking at more end-of-life discussions and more focusing on really, for the most part, it was families at that point whose loved ones were nearing end of life. So more, at the end of life phase. But what we realized is no one was really comfortable and prepared for those goals of care discussions. So this project, we realized we had to back it up. And staff in particular were telling us that they weren't comfortable having really any of these conversations. So we sought out an educational program, which certainly it's hard to find one just looking at communication, although there's lots that have emerged recently. But we lured in Jane Webley, who's a clinical nurse specialist in BC. Some of you may know her, who had been doing a fair bit of training on this topic. So we had her come to Hamilton. It was a 2.5-hour training, really just focused on communication and trying to equip staff with some of the skills and knowledge and confidence to engage in these conversations. So we did do a little bit of role play as well, and it was primarily focused on using the Conversation Starter Kit tool. So next slide, please, Michelle, thanks. So what we did to evaluate the workshop, we did a pre-survey and we did a post-survey. We looked at all levels of staff, all different kinds of healthcare providers, really targeting our palliative champion teams. Those were our go-to people for most of our initiatives that we were engaged in. So we had, a good variety of staff to get involved with our education. But what was most interesting to us, you can see here in the bar diagram, the staff groups who had the lowest comfort level, or at least reported the lowest comfort levels with engaging with end-of-life discussions and supporting families and residents, were the personal support workers or healthcare aides and the support staff. And support staff being, rec therapists, dietary aides. I think we had housekeepers as well, because we know in long-term care that those healthcare providers are often asked questions from families and residents. So they're often in a position to have these conversations, or these informal conversations that Tamara has spoken about. So they had the lowest rates, but you can also see that they improved the most. So this really got us thinking, and we've had other work as well in this area. You know, those two groups of healthcare providers in long-term care really, we really need to focus on providing some education and training for them. There's, you know, lots of training for registered staff. The LEAP long-term care is a popular one and one that we've used. But often PSWs, healthcare aides, and support staff aren't invited to a lot of those educational sessions. So I'll go next slide there, please, Michelle. Great. So similar trends in the results here. You can see the PSWs and support staff. Everybody improved a little bit, so that's good. But these two groups really stood out from the others as benefiting the most from attending the workshop. And in this case, you know, looking at improvements of perceptions about advanced care planning. And certainly we've learned from a lot of our other work, people not really understanding, staff really not understanding what advanced care planning is. When we've asked them, you know, they talk about CPR, planning for the funeral, but there's, you know, as we know, a lot more to advanced care planning than that. So that was the evaluation of our workshop. And from that, we've actually moved on to develop some e-learning modules that we're evaluating right now for this target population. So for personal support workers, healthcare aides, and support staff. So we have 8 modules. And just a shout out for some other resources that are new. CHPCA have launched their PACE, so their education for PSWs, which certifies PSWs and implementing a palliative approach. High uptake on that, as well as the LEAP PSW education as well. Next slide, please. Thanks, Michelle. So in terms of our methods, to collect all of our data, we had 3 long-term care homes in Ontario that we worked with, excellent homes. And as Tamara mentioned, we were really targeting residents who were more medically stable. So usually soon after admission, and we used the CHESS score to determine that group. We wanted people who could engage in conversations and could be involved in advanced care planning. The opposite to what our other study was focused on at end of life. So we wanted to specifically recruit residents who could engage in the study with us. So just briefly, we gave out the Conversation Starter Kit booklet. We collected baseline data before that. And then we gave residents 1 month to complete the booklet and encourage them to reach out to their family. Some did, some didn't, to have those discussions. So really what we wanted was to get residents engaging in conversations, hopefully with families or their substitute decision maker. And we also were encouraging them to talk to staff and ask questions with staff. So that was one of the things we were hoping, but we didn't, you know, it was optional. We let them to decide. Next slide, please, Michelle. Thanks. So we were quite fortunate to be able to recruit 44 residents. This is not an easy population to find cognitively intact residents who could, you know, engage in our study. So we were pleased with that sample size. And what was interesting for us, we had a scale and we had some subscales within it. This is one primarily focused on advanced care planning, engagement in advanced care planning. And we found that after residents had received the booklet, used the booklet, they reported that they were asking more questions to their healthcare provider. And that was statistically significant. So a good finding for us. We were happy about that. And the next slide will focus on, we had families also complete a scale looking at self-efficacy and decision-making. So we wanted to find out from families after having talked with their loved one or the resident in long-term care, about how confident they were if they had to make decisions on behalf of the resident. So at time one, interestingly enough, they felt they were very confident. So this was before they actually had looked at the booklet and met and talked with the resident about the booklet. But after they had those experiences with using the booklet, they felt less certain or less confident. So, you know, of course, this is like, oh no, as a researcher, it's like the complete opposite that we had hoped to see. But once I settled down and started thinking, and I think the light bulb went off with Tamara before me, it usually does. But I realized that this actually could be a good finding, because introducing the conversation starter kit tool could actually trigger them to realize that they need to have more of these conversations, and they need to be better prepared for some of these decisions down the road when they would have to make them on their own on behalf of the resident. So we saw it in the end as a good finding, that it's raising awareness and highlighting to families the types of conversations and information that they need to have. So it gave them some time in order to do that. Next slide, please, Michelle. Thanks. So some of the processy things that we looked at, these are examples of questions on the booklet. And the first question, you know, finding out for the resident what do they want to know about their condition, because we all know there's some people who don't really want to know too much, where other people, you know, they want to have all the nitty-gritties of the details. So our findings, I think there might be another click. Yeah, there we go. So essentially we found that most residents, the large majority, 75% of them, actually wanted to know all the details about their condition and their treatment. So that was good information to have. And also asking them about, as doctors treat me, I would like, let me just say. So yeah, so how much do they want to be involved in those decisions? And again, 70% of them said that they do want to be involved in those decisions. So again, really showing that they do want to be engaged and active in being informed about their condition and making decisions about them. One more slide, Michelle, or maybe two more. There we go. And then asking how involved they want their families or friends to be. So here we see kind of where they want families, they want families to do and make decisions more on their behalf than offsetting the burden to families, because what we have heard as well in some of our other studies, you know, that residents don't want to burden families and just want them to make the decisions. But this really supported the notion that, you know, that residents want their wishes upheld by families. So even if it makes families a little uncomfortable, they want their wishes and their preferences for care upheld. Okay, next slide, Michelle. Great. So here looking at, again, looking at some of the, so these are coming from Tamara's publications, in case you're wondering. She speaks much better to these findings. And we do have those references for those of you who want to take a look at them. But essentially, the advanced care planning and the conversation starter kit tool, really, it was clear that it promoted reflection and preparing residents and families to have these conversations and reflecting on some of the communication. We saw a little bit of action, which was something we hadn't seen in our previous work with residents actually asking questions. But I think what would be even better is seeing some more conversations with staff and having staff support residents and families better within advanced care planning. All right, and I think we're on the last slide. There we go. So conclusions and recommendations. I think, you know, certainly what I've learned the most through this study, and I think, you know, Tamara probably would agree, is we really need to optimize these informal conversations. So and those informal conversations often happen with PSWs, healthcare aides, the support staff. That's when you hear these tidbits of information that I don't think we recognize as being important and valued. But we need to pay attention to some of those conversations and make sure that they're shared with other people, documented, and discussed at care conferences. Certainly, we need lots of training for staff to be able to feel comfortable engaging in advanced care planning and supporting residents and families. And we need to help them feel empowered to have these conversations. The Conversation Starter Kit booklet was really a wonderful tool to get the conversation started. And I think families and residents all really appreciated having something to focus their conversations on and to write notes as well. And having a self-directed tool that had a large psychosocial component to it is important. So when residents and families are ready to have these conversations, you know, they have the toolkit there handy for them to use. All right, and I think we have, next slide is some publications you'll see here, and Tamara has nicely put links so they're easy to access, and it sounds like you'll be getting these slides, so you'll be able to access them fairly quickly. And then some upcoming references on the next slide as well that are coming down the pipes. We're wrapping up this study. It's been a very busy study, but we've really enjoyed it and learned a lot. So I think now we can open it up to questions. And Jeanette, it sounds like you'll be moderating the questions.
Yes. First of all, just thank you, all of you, for that wonderful presentation. We've got quite a few questions, so I'll try to go quickly through them. So the first one is for Dr. Howard. How come home care was not involved together with physicians and acute care hospitals and care homes?
I can speak to the family practice aspect. Yeah, home care. Yeah, I guess it just, we didn't consider as part of the pathway, we were really focused in this project on just those professionals who work in the actual practice itself. But yeah, I think that is definitely a very important group of healthcare professionals that can have a major role in here and communicating back and forth with the family practice. So yeah, I appreciate that being brought up, and yeah.
Great, thank you. Next question is, and it's not directed particularly at any one person, so whoever feels like they'd like to jump in first, please feel free. So how did you address the differences in the law related to healthcare consent and advanced care planning across Canada when doing this research, since the legislative differences affect what to explain to people engaging in advanced care planning?
I can comment from the primary care perspectives in the two provinces we worked. We always started in the patient engagement with the public education materials with the locally relevant materials, so the participants would get the information that applies in their setting. And then the interventions were developed with clinicians who were expert and knew the legislation and legal issues with their province as well, and actually recommended the forums to use and had been through lots of education around these things themselves. So each place was like, the approach was tailored at each place to address those specific issues in our study.
Great. The next question is, much of what people call advanced care planning should actually be discussions about informed consent. At end of life, people are most likely able to give or refuse consent to possible treatments rather than speculate about future care, as advanced care planning is thinking about this stuff out of context of actual state of health. Did you find this challenge? So that's to anyone on the panel there.
You know, I think that the $1 million challenge is sort of separating decisions from getting at people's values and getting at what's behind those things. I think in all of our studies, Michelle's done so much work on this. What we're aiming to do is help people get better at just clarifying what people's values are and what could happen down the pipeline to compromise those values, so that families feel more equipped if they need to be in a position to make those in the moment decisions to make them. So we're really not talking about decisions made in advance, but that's such a confounded idea in all of our health practices. And I saw it in the tools, in the 611 tools that we looked at. So many of them were about priming people to make advanced decisions versus, really thinking about what's important to me. What are the things I want to share with my families that may be considered in the moment? Certainly in our component, we didn't focus a lot on the discussions about what the condition is. But as Sharon said, we did try and get a sense of how much do people want to be informed? How much do people want decisional flexibility in their decision makers, or how much do they want their ideas implemented as is? And those things are really important in terms of centering the resident across the journey. So I think that's the ongoing probably work. And just to sort of take the question around what we did with our tools. So we had the Ontario Hospice Palliative Care Association vet the conversation starter kit in Ontario, and we also had some legal folk in Quebec to kind of have a look at some of the information we were providing.
Great. So the next question that I have here, sorry, I just lost it. Can you please elaborate on the roles you found for allied health?
Yeah, so I think this question actually came up before before we did our presentation. So it may be more directed to primary care, because I think we probably addressed our allied health piece pretty well. Yeah. Michelle, did you want to comment?
Sure. Yeah. Yes, we did have allied health in each of those settings. One was a nurse, one was a social worker, and that was really an explicit intention. So what the practices found, or through working up this pathway, was that the allied health could do the initial engagement and actually doing some teaching of the patients, including the informed consent and all those issues. I didn't really go into all the things that they discussed, but they were trained on that as well. So they did that kind of work, and they also talked to the patient. They went through those values kind of questions. So at no point was anyone making any decisions about treatments or anything in our project. It was really all focused on those values things, but they prepared the patients, and they also prepared the physician for this is kind of where your patient's at, this is what they're thinking, and it really shortened that conversation and made it a lot more informative and focused when the physician was talking to the patient.
Great.
So that was the role that seemed to be a benefit.
So related to the values, someone is asking if the values clarification tool that was used in primary care, is that available to the general public?
Yeah, good question. It was kind of made up in a beta version, and we took existing value statements from the literature and used a technique our colleague Nick Vance back in BC actually creates these sorts of tools as a decision scientist, where people just had to pick from the terms which were most important and least important to them. And it was on a website, and I'm not sure if it's still active because it's been a little while since we completed our project.
Okay, but perhaps if it is, maybe we can link.
I can
that
certainly, yeah, I can provide it. Yeah, if it's still there.
Yeah, that would be great. So one question here for Sharon. I think it's great that you use chess score from the MDS 2.0. Just curious if you've done other analyses using the MDS 2.0 data, or maybe these are planned. For example, could be very interesting to use the data to look at your outcomes across different characteristics like age, sex, marital status, and scores on things like the depression rating scale, the pain scale, etc.
Thank you, Dawn. Great question. You're welcome to use our data set. I'll say that. Really good question. We just really focused on very pragmatically using the chess score for our recruitment. But I think what you suggest is excellent, and happy, you're welcome to see our data.
We love to see collaboration coming out of these.
That's right.
Another question here, just because we're getting close to 1 o'clock, but I'll try and squeeze in as many as we can. So this participant says, I am 80 years old. I have included MAID in my ACP as I do not wish to go into an LTC home. I want peace, not what others would wish. My question, and then they say, what are the reasons MAID was not included in this presentation?
Great question. And we actually, when we did interviews with residents and families, you know, this came up in our qualitative findings. And, you know, at the time we were doing this study, I mean, you know, everything was changing around MAID because we collected our data. It's been at least, I think, 4 years since we collected our data. So the landscape of MAID, you know, was really in flux at that point. And the other thing we had thought, you know, there's some excellent resources. I know CHPCA has done some work, and you can find those on their website. So to do it justice, you know, I think it's a topic that comes up. So I guess that's one of the things we can use the booklet for is, you know, some of those questions come up, and that's the benefit of having conversations with staff too. So staff, you know, can help support those conversations and help find information for families and residents. But very good question, and it's certainly one that came up in our findings. So I think it's one that needs to be considered. Thank you.
And if it's all right with the three of you, I'll just ask one final one, and then we'll sign off for this webinar. Is that all right? Yep. Okay. So this individual says, I know that one of your recommendations in primary care was to partner with community groups to start the conversation. Do you have any examples where this is actually happening?
Yes, just for the sake of time, I took out a little kind of sub-project that came out of this idea, and really the BC Centre for Palliative Care has been doing direct community education through lots of community organizations on advanced care planning for quite a while, and they've created the tools and resources and the binder and everything for doing that and training up volunteers to do that. So we actually did start to embark on some work to ask family doctors if they would refer patients to it. Like they might refer them to lots of different things, and we kind of got stuck when the pandemic hit and all those things stopped happening in person and things had to change. So we did do a survey that we're working on publishing very soon about what family doctors thought about it and what would help them to refer. So that will be coming, and there was quite a lot of positive endorsement for that idea. They would love to be able to refer their patients in the community to something like that.
Wonderful. Well, thank you again, Drs. Sussman, Howard, and Castellanen for joining us today. We have some questions left unanswered and some comments, but perhaps we can share those with you and some requests for resources. So we'll do what we can to connect our participants today with the information that you've shared. Thank you once again for joining us today, and thank you to everyone who listened in. A reminder that you can catch this webinar as well as the slides at cfn-nce.ca/webinar, and we look forward to having everyone join us next week for part 2 of this session. Thanks so much. Have a great day.